Okay, so now we're moving on to section 6 of chapter 17, where we're going to talk a little bit about hemostasis. And hemostasis is basically a series of fast reactions that helps prevent blood loss. It requires a couple different things. It's going to require clotting factors. These clotting factors are normally found in our blood plasma. And it's also going to require a bunch of chemicals and substances that are released by the platelets and the injured endothelial cells themselves. There's 3 general steps that are involved. Vascular spasm would be the first step, platelet plug formation is the second step, and then coagulation or blood clotting would be the final step. After we form our clot, it is going to retract and it'll eventually dissolve and be replaced by a fibrous tissue, and that will be like a permanent way to prevent blood loss in the future. So the first step is vascular spasm, and anytime our endothelial cells or our tissue in our blood vessels is damaged, the response to that damage is going to be for the blood vessel to constrict, so vasoconstriction. A lot of different things can trigger vascular spasms, so direct injury to the smooth muscle within the blood vessel itself. Also, when we damage those endothelial cells, they will release chemicals that will also cause vasoconstriction. And once we activate our platelets, which we'll talk about in a little bit, we also have some pain receptors that can also initiate some reflexes to help with the vascular spasm process. But once we begin it, it becomes more and more efficient as the amount of tissue damage increases. And pretty much the process of vascular spasm is really just to quickly prevent huge amounts of blood loss by reducing the amount of blood flow until we can get the remainder steps or other mechanisms on scene. So the next step is going to be platelet plug formation. So this is where platelets come in and play a huge role, because they're able to aggregate or stick together. So when these platelets aggregate, they form a temporary plug that helps seal that break in that blood vessel. Pretty much, platelets don't stick to each other or to the smooth muscle cells that line the blood vessels, because we are normally releasing nitric oxide and prostaglandin. So as long as we have the release of nitric oxide and prostaglandin from the healthy endothelial cells, our platelets will not stick together. So those 2 chemicals are going to prevent platelet aggregation. But when the endothelial cells are damaged and the tissue is damaged, there's collagen fibers that lie underneath the endothelial tissue. And when those collagen fibers are exposed, because there's a cut or damage, those platelets begin to start adhering to the collagen fibers that are visible now. So a huge plasma protein called von Willebrand factor is going to help stabilize those platelets that are kind of floating on by to help form a bridge to connect the platelets themselves to the collagen fibers that are now exposed. Once we have the von Willebrand factor connecting the platelets to the collagen fibers, we can then say the platelets are activated. Once those platelets are activated, they start to enlarge. So they'll swell a little bit, they'll start forming these spike-like processes, and they become even stickier than they were to begin with. Also, activation causes them to release additional chemical messengers, things like ADP. And ADP release is going to cause more platelets to come stick to the area and release their contents. The activated platelets can also release serotonin and thromboxane A2, which is really just a chemical messenger to help enhance the vascular spasm process as well as platelet aggregation. So if you remember again from AMP1, and we talked about feedback, so positive and negative feedback, platelet plug formation is actually a positive feedback cycle. So once we start activating our first platelets, those release chemicals to activate more platelets and eventually form a clot based off of this positive feedback process. For most tiny tears that we have occurring in our body throughout the day on all of our blood vessels, step 2 and plugging it with the platelet is sufficient. However, if we go in and we have a major break in our blood vessel, we need to move on to step 3. And step 3 is coagulation or blood clotting. So this is going to help reinforce that platelet plug by making what we call like a fibrin mesh. And that fibrin mesh is the blood clot itself. And once we place this fibrin mesh down, it becomes really effective at sealing those larger breaks in the blood vessel. So basically, we're able to transform the blood from its liquid form to like a gel-like form as we get those dissolved blood proteins coming in to connect with those fibrin threads. So coagulation is more than one step. It's a couple of different steps or a series of steps, and it requires several different clotting factors. The big thing I want you to understand, or the takeaway from coagulation, is within these steps of coagulation, what are we beginning with and what is the end product of that phase? What else do I need? They were ordered in the number of discovery, so 1 through 8, not the order in which the clotting factors are used in these series of steps. So you'll see like they're out of order. It doesn't go 1, 2, 3, 4, 5, because again, it was by order of discovery. We also need vitamin K to synthesize 4 of these factors. So vitamin K is essential in our diet in order for us to properly form blood clots. So let's move on to these phases. So these are the 3 phases in a big picture. There's 2 different pathways for phase 1, which we'll talk about in a little bit, intrinsic or extrinsic pathway. Phase 2 is pretty simple, and phase 3 is pretty simple as well. So most of our time will probably be spent on phase 1. So like I just mentioned, when we're talking about phase 1, there's 2 pathways, either intrinsic or extrinsic we can take. Typically, both of these pathways are activated when we have some sort of tissue damage. So what would trigger it? Any type of tissue damaging events, and it involves a series of those procoagulants. Again, the whole point of both of these pathways is you'll see that they end with the activation of clotting factor X or clotting factor 10. Once we have clotting factor 10, that's going to complex with calcium, platelet factor 3, also known as PF3 previously, and clotting factor 5. Once we have clotting factor 10, 5, calcium, and PF3 together, we then form what's called the prothrombin activator. So what's the difference between the intrinsic and extrinsic pathway? Well, intrinsic is when all the clotting factors that we need for this pathway to occur are in the blood itself, so within. Extrinsic pathway means that some of the clotting factors we need for the pathway are located outside of the blood. So what's going to trigger this pathway is basically exposure to tissue factor, which is also called clotting factor 3. A good thing about the extrinsic pathway is that it can bypass several of the steps of the intrinsic pathway, so it's a much faster pathway. So here's just the overview of phase 1, and here's the intrinsic pathway and extrinsic pathway. You do not need to understand all of this middle part. I really just want you to understand what intrinsic is, meaning we can take that pathway because we have the clotting factors in our blood already, or extrinsic pathway, meaning some of the factors we need in order for this pathway to occur are found outside of the blood, in which case it's tissue factor. So we need tissue factor for the extrinsic pathway. The intrinsic pathway begins with clotting factor 12. You'll notice on this flow chart that we see that we turn 12 over here into 12A. All that means is that once we take clotting factor 12, and we turn it into 12A, we basically activated it. It's the activated form. And then 12A goes on to activate clotting factor 11, which then becomes activated clotting factor 11. Again, you don't need to know that. I'm just explaining to you what the little a's mean. So for intrinsic pathway to occur, we have all the clotting factors that we need. We need clotting factor 12 to begin with. If we're talking about extrinsic pathway, we need or require a clotting factor that lies outside of the blood, which is tissue factor or TF. Doesn't matter which pathway we take, the goal of it is to produce the thrombin activator down here, which is a complex of clotting factor 10, clotting factor 5, and calcium and PF3, which is not listed here. So what does each pathway start with? What is the end goal of the pathways themselves? Also recognize that extrinsic pathway occurs much faster because there's less steps involved. So we made in phase 1 our prothrombin activator, so then we can move to phase 2. And phase 2 is pretty simple. Basically what we're doing is we're taking our prothrombin activator and we're activating thrombin. That was the whole purpose of making that in phase 1. So prothrombin activator is basically going to come in and catalyze the conversion of the plasma protein prothrombin into an active enzyme, which we call thrombin. So we start with prothrombin in phase 2, we end with thrombin in phase 2, which we're going to need for phase 3. So here's phase 2. And then here we need the prothrombin activator from phase 1 in order for this to occur. So the end result of phase 2 is thrombin, which, as you can imagine, we're going to need thrombin to help with phase 3. And phase 3 is really just called the combin pathway to the fibrin mesh, because the fibrin mesh is going to be the end point of phase 3. And the fibrin mesh is really great because it's going to help trap those blood cells and effectively seal that hole or that tear in that blood vessel until we can permanently repair it. So we're going to take the thrombin that we made in phase 2, and that's going to come in and catalyze the transformation of fibrinogen into fibrin. And those fibrin molecules, after they have been transformed into that, are going to polymerize, meaning they're going to link end to end and eventually form a really long, thin, and soluble fibrin strand. The fibrin strands are then going to come together and help glue those platelets together and basically form like a web-like structure that is going to be the clot. If you've ever heard of an anticoagulant, the function of the anticoagulant is going to inhibit blood clotting. So here's phase 3. We have our thrombin that we produce from phase 2 that is required in order for phase 3 to occur. And it's going to come in and turn fibrinogen into fibrin, which is going to polymerize or link together to form this cross-link or fibrin mesh. Also, we require activated clotting factor 13. So here's an overview of coagulation, a blood clot formation. So we have a vascular spasm where we're going to have several different things being released or chemicals that causes the smooth muscle lining our blood vessels to constrict. That's going to temporarily prevent blood loss until we can come in and start our platelet plug formation. So the damaged endothelial cells are going to start releasing chemicals to cause more platelets to come on by. And when we have damaged epithelium, directly below it lies connective tissue. and connective tissue is going to contain the collagen fibers. So once we expose the connective tissue with the collagen fibers from the cut, our erythrocytes that are passing, our platelets that are passing by are going to start adhering to those collagen fibers that are exposed in the connective tissue that lies just deep to that endothelium. We need the von Willebrand factor to come in and help form the cross bridge between the platelets and the collagen fibers that are exposed, at which point we have activated the platelets. Activated platelets are then going to release more chemicals that attract more, and we have a positive feedback cycle. A lot of times, if you look right here, this platelet plug formation is sufficient in really small tears. But if we have any substantial damage to our blood vessels, we need to move on to step 3, which is coagulation. And that's where we move through phase 1, phase 2, and phase 3 until we finally produce the fibrin mesh that will become the blood clot itself. So here's an overview again. And here's a picture of the fibrin mesh itself. And here's just a list of the clotting factors. I don't expect you to know their names. I really just want you to understand what things start with in each phase and what the end product of each of the 3 phases is. So once we've laid down the clot, the blood clot or that fibrin mesh, eventually we have to go in and retract it and lay down some actual tissue in order to have a permanent seal. So we have the next step, which is clot retraction, and we have actin and myosin that's in the platelets themselves that's going to contract within 30 to 60 minutes of laying down that mesh clot. So the contraction is going to cause those fibrin strands to be pulled on, and what's going to happen is serum is going to squeeze from the clot. And basically, what is serum? Serum is the plasma minus the clotting proteins. And then eventually we're going to draw the ruptured blood vessels edges together until we basically seal it there. So once we have clot retraction, then we need fibrinolysis. And so a clot really isn't a permanent solution to any blood vessel injury. So we need to go through the next step, which is fibrinolysis, where we remove the unneeded clot once the healing has occurred and go in and kind of clean up the whole thing. So 2 things that we need, platelet-derived growth factor, or PDGF. This is going to be released by the platelets themselves. And PDGF is going to come in and basically stimulate those smooth muscle cells to undergo division so we can produce more. And also is going to stimulate fibroblasts to help come in and rebuild the blood vessel wall. We also need VEGF, or VEGF, which is vascular endothelium growth factor. And the whole purpose of this is to stimulate the endothelial cells to multiply and restore the endothelial lining. So 2 really important things that we need in order to form and rebuild that blood vessel wall. Fibrinolysis is basically where the clots are removed after the repair is complete. And again, it begins a couple days and continues for several days until we've completely dissolved that clot. Something that's required for it is plasminogen, and that's a plasma protein that was caught in that fibrin mesh. And plasminogen is going to be converted into plasmin, which is an enzyme that can go in and digest that fibrin. And we also have TPA, or tissue plasminogen activator, and some other things that play a role, but I don't expect you to know those. So factors limiting clot growth or formation. Once the clotting cascade has started, it's going to continue regardless until the clot forms. So there's 2 mechanisms that can prevent the clots from becoming too big. One is we remove the clots really, really fast, including the clotting factors, or we inhibit the activated clotting factors that are already activated, because we don't want to continue it so that it continues to grow larger than we need. So we have limited amount of thrombin is going to be restricted to the clot by those fibrin threads, which we just talked about, and that's going to help prevent the clot from getting too big and or escaping into the bloodstream, where it can form a clot somewhere else where we don't actually want it to. So we have antithrombin 3, which inactivates any unbound thrombin. So it doesn't escape into our bloodstream and go on to go do damage elsewhere. Also the heparin that's in basophils and mast cells that can inhibit thrombin by enhancing antithrombin 3. We also have factors preventing undesirable clotting. So remember I mentioned as long as our endothelial cells are intact and healthy, platelets are prevented from clinging and piling up. So also because they're releasing nitric oxide and prostacyclin. So we have antithrombic substances, which would include the nitric oxide and prostacyclin, but we also have others that can be secreted by endothelial cells that normally prevent platelet adhesion. So things like vitamin E is a really potent anticoagulant. When we're talking about blood clotting, there's two major types of disorders. One's thromboembolic disorders, and the other one would be bleeding disorders. If we're talking about thromboembolic disorders, these typically result from conditions that cause undesirable clot formation. If we're talking about bleeding disorders, this has to do with abnormalities that prevent the normal clot from forming to begin with. We also have something called disseminated intravascular coagulation, or DIC. And DIC has characteristics of both thromboembolic disorders as well as bleeding disorders, and involves really widespread clotting and severe bleeding. So let's start with thrombi and emboli. So what is the difference? If we're talking about a thrombus, that's a clot that develops and persists in an unbroken blood vessel. And if we have a clot that develops in an unbroken blood vessel, that can lead to a block in the circulation or blood flow in that vessel, and eventually lead to tissue death if it remains there for an extended period of time. If we're talking about an embolus, this is a thrombus or a clot that is freely floating in the bloodstream. And if we talk about an embolism, this is an embolus or freely floating blood clot that's obstructing a vessel. So if you've ever heard of a pulmonary embolism, that would be a thrombus that's blocking one of the blood vessels in your lungs. So several things can contribute to your increased risk of thrombi and emboli, and those are things like atherosclerosis, if you have inflammation that's chronic, slow flowing blood, so high viscosity, or blood stasis from immobility. So if you have some sort of thromboembolic condition, a lot of times you want to take an anticoagulant. So there's a number of drugs, things like aspirin, heparin, or warfarin, that can be clinically used to prevent clotting that we don't want to happen. So aspirin is going to be an antiprostaglandin drug. What it does is it inhibits thromboxane A2. So it's going to block that platelet aggregation and platelet plug formation. Heparin is typically administered via injection. It's also an anticoagulant, mostly used in the hospital on heart patients that are about to undergo some procedures, or as a preventative measure to treat blood clots that you might have in your veins. The third one is warfarin. So that's an oral drug. Excuse me. So a lot of times it's used in outpatient treatments because it doesn't have to be administered via IV, and it's going to help reduce the risk of stroke in patients who are prone to atrial fibrillation. And atrial fibrillation is where you have blood pooling in your heart. So how does it work? It interferes with the action of vitamin K. which I told you 4 of the clotting factors need vitamin K in order to be produced. So if we interfere with the production of action of vitamin K, then we're not producing all the clotting factors that we need. Some other disorders can be bleeding disorders, so something like thrombocytopenia. This is really characterized by a low number of circulating platelets. A lot of times, or if thrombocytopenia is really severe, it can cause bleeding from all of your tiny blood vessels all over your body. And when we have these tiny little bleedings from these tiny tears in our small blood vessels all over our body, it leaves these purplish spots called petechiae. And I think I have a picture. So this is what petechiae looks like. We don't have enough platelets in our body, and every time we're breaking our blood vessels, really, even if it's really, really small or minor, we don't have the platelets to go in there and form that platelet plug. So we have these little small hemorrhages that are occurring all over our body that leave these petechiae spots. So when we're talking about hemostasis and bleeding disorders, we can have impaired liver function. And if we have impaired liver function, that's going to lead to the inability for us to synthesize procoagulants, so all of those clotting factors. It can also, causes also include vitamin K deficiency, hepatitis, or cirrhosis. And if you have liver disease, it can also prevent the liver from producing bile, which we'll talk about when we hit the digestive system, which is needed to absorb fat and vitamin K. So we definitely need vitamin K. It's essential in order to produce all of the clotting factors we need in order to form our platelet plug. So hemophilia, basically hemophilia refers to a bunch of bleeding disorders that have a genetic base, so through hereditary. Hemophilia A, hemophilia B, and hemophilia C. If we're talking about hemophilia A, that means we're insufficiently producing the clotting factor 8. Hemophilia B is the result of a deficiency in a different clotting factor, and it's clotting factor 9. Hemophilia C is not as severe as hemophilia A and hemophilia B, but it's due to the lack of having clotting factor 11. And I just briefly want to touch on disseminated intravascular coagulation, or DIC. Like I mentioned previously, DIC involves both widespread clotting and severe bleeding. So typically the clotting is going to occur in healthy, intact blood vessels when we don't want it to. And then we also have blockage of blood flow that can be accompanied by severe bleeding. So if we're talking about DIC, it's really common when we talk about pregnancy complications. Also, if you have septicemia or if you receive a blood transfusion with an incompatible blood type.